Thank you very much for introduction, and sorry you have to see me giving presentations too many times today, but you will not see me tomorrow or after tomorrow. I don't have more presentations, so I'm very sorry. I'm going to talk about role of glycemic control in type 2 management, early and tight. So we are going to talk about how to be early and how to be tight. According to the latest IGF Atlas, we are now having 536 million patients living with diabetes and expected to be 783 millions by 2045. And in Egypt, we have more than 11 million persons living with diabetes, and by 2045 we're going to have more than 20 million persons living with diabetes. How to be early and how to be tight in diabetes management. Let me start with early. And according to the ADA, this is the recommendation when to screen for diabetes or pre-diabetes in asymptomatic population. And for persons with no risk factor, like obesity or hypertension or previous gestational diabetes or delivery of a big baby or polycystic ovary syndrome, these are known risk factors for diabetes. For persons with no risk factor, we should start screening for type 2 diabetes at the age of 35. And let me remind you that previously, in the previous guidelines, it was 45, not 35. So we have to screen patients to detect cases early, starting from 35 years of age if they don't have any manifestation of pre-diabetes or risk factor, apparent risk factor for diabetes. And this is the diagnosis criteria for pre-diabetes: fasting plasma glucose of 100 milligram to 125 milligram, and the 2 hours is after 75 gram oral glucose tolerance test, 140 to 199 milligram, or hemoglobin A1C between 5.7 to 6.4%. So to be tight, we should start early after diagnosis of type 2 diabetes. This is the type 2 management current situation. At diagnosis of type 2 diabetes, we are having 50% of the patients are having at least one complication. And there is studies showing 37% are having 2 complications at diagnosis of type 2 diabetes. And up to 50% of beta cell function is lost. And the current management, and in spite of the new medications and frequent new medications, 2/3 of the patients do not reach the hemoglobin A1C target. Majority of diabetic patients require polypharmacy by time to reach the glycemic goal. This is a very interesting study. Those persons who were participating in the UKPGS many years ago, some of them are still alive, and after 44 years of UKPGS, they are studying the legacy effect, and this study was presented in ESCG 2022. This is a very new study, and after 44 years of the UKPGS study, for early intensive blood glucose control with insulin or sulfonylurea, there was reduction of 11% of deaths and 26% of diabetes complications, kidney failure, and vision loss. And for early intensive blood glucose control with metformin, there was 31% reduction in heart attacks and 25% reduction in deaths. So this is the benefit of early and strict, tight glycemic control. Whether to use early combination or not, and the combination therapy is having increasing evidence and rationale due to increased durability of glycemic effect by the use of oral combinations and addressing the therapeutic inertia with starting combination of two medications together. And combination usually target multiple pathophysiological defects characterized in type 2 diabetes. There is a potential impact on burden of diabetes, medication burden, adherence to medication, and treatment persistence. If the patient is having combination, then it's easier than taking like 4 or 5 tablets per day for managing type 2 diabetes. And there is complementary clinical benefits in glycemia, in weight, in cardiovascular risk profile. And this is new, again, the ADA with EASD talking about combinations. And let me highlight, there is very high potency and efficacy of these medications, which are dulaglutide high dose, semaglutide, tirzepatide, insulin, and combination oral treatment, combination injectable treatment, GLP-1 receptor agonist with insulin. So this recent guidelines showed the very high efficacy of these different combinations, including combination oral treatment. Let me start talking about sitagliptin in early diabetes management and the DPP-4 inhibitors according to ADA-ESCG September 2022. They give intermediate glucose lowering efficacy, but we know that if they are combined with metformin, they are going to be highly effective, and we're going to check the studies later on. They are generally well tolerated with minimal risk of hypoglycemia, and early combination treatment with metformin and DPP-4 inhibitor, like the famous study of Verify using vildagliptin, it increased glycemic durability compared to stepwise approach. Then the Verify trial was mentioned frequently in the ADA guidelines previously, and then in the ADA-ESCG about the combination, the early combination of vildagliptin together with metformin having glycemic durability and when compared to stepwise approach. There is cardiovascular safety in DPP-4 inhibitors use. What about sitagliptin metformin combination? And this combination targets the metabolic defects of type 2 diabetes. Metformin will improve insulin sensitivity in the liver and muscle. Metformin will reduce hepatic glucose output, decreasing gluconeogenesis and glycogenolysis. Sitagliptin will improve beta cell secretion of insulin, synthesis and release. Sitagliptin will decrease carbohydrate production or glucose production, and it suppresses glucagon release from the alpha cells. This is a research differentiating co-starting sitagliptin with metformin. What if we give both sitagliptin with metformin and compare it with giving sitagliptin after metformin? So this study is co-starting sitagliptin with metformin was associated with lower likelihood of disease progression in newly treated people with type 2 diabetes, a cohort study. This was the study, type 2 diabetes over 18 years, and one arm received co-start of sitagliptin with metformin in 1,100 patients and compared with sitagliptin added later to metformin in 7,600 patients. And the primary endpoint was initiation of insulin and hemoglobin A1C change 1 year after starting sitagliptin. And the result about the primary endpoint of insulin initiation: co-starting sitagliptin with metformin was associated with lower chance of starting insulin. And let me give you this figure. In patients receiving co-starting of metformin with sitagliptin, there was reduction of hemoglobin A1C of 2% between 9.4 and 7.4, while in those who received later sitagliptin, there was reduction of 1% hemoglobin A1C. But after stabilization of all parameters, this 0.5% reduction in hemoglobin A1C was shown between the two groups. So co-starting sitagliptin with metformin after 1 year was better 0.5% hemoglobin A1C reduction than delaying the start of sitagliptin. And the conclusion in this study was fewer insulin starts and greater degree of hemoglobin A1C reduction. And these observations suggest that co-starting sitagliptin with metformin delays the progression of type 2 diabetes. A new treatment approach to early type 2 management. If we're going to start a combination from the beginning, then we are not going to follow the stepwise approach on the left side, and we are going to early oral antidiabetic combination with sustainable hemoglobin A1C reduction from the beginning. Another study about initial fixed dose combination with sitagliptin metformin versus metformin monotherapy. And this is a study design, and those are the two arms. And the initial fixed dose combination with sitametformin versus metformin monotherapy, this is the baseline change in hemoglobin A1C. And let me confirm the evident result of reduction of 3.6% hemoglobin A1C in those patients with a baseline more than 11% hemoglobin A1C. But in lower baseline hemoglobin A1C, we can expect a reduction of 2.9 or 2% hemoglobin A1C. Sitagliptin has maintained efficacy in this study versus sulfonylurea after 30 months of the use of sitagliptin. Both sitagliptin metformin versus sulfonylurea were having the same potency, but later on whether sulfonylurea in the upper curve or pioglitazone in the lower curve, sitagliptin metformin had better sustained effect after 60 months of the study. So we finished early control results, and we're now going to tight control. And usually we have clinical inertia in type 2 diabetic patients. And this is an evidence from large real-world data. We can find a percentage of patients who are not reaching the target, and for all patients, 37% are not doing intensification of treatment. And for those patients with hemoglobin A1C 9% or more, those with no intensification were 44% of the group. Then we are having 44% of patients with hemoglobin A1C 9% or more, and they didn't do intensification. This is most alarming. And delay in treatment intensification was shown in this trial. Those who were delayed for 1 year in intensification, they had serious complications, increased myocardial infarction by 67%, increased stroke by 51%, increased heart failure 64%, and cardiovascular events was increased 62% in those with delayed treatment intensification. This is the new ADA ESG this is a new ADA for management of diabetes complication, and in order to reduce diabetes complications, we should do lifestyle modification and diabetes education together with glycemic management, blood pressure management, lipid management, and targeting cardiovascular and kidney side effects or complications. And this is the summary of glycemic recommendation according to Diabetes Care 2022. For patients with early onset diabetes, we may go for more tight glycemic control. For those with old age, we go to less strict diabetes control. For those with comorbidities like kidney, liver, or heart disease, we go for less glycemic control. For those with short lifespan, we go for less tight glycemic control. For patient preferences, sometimes a patient is having sense of hypoglycemia, he may prefer less tight glycemic control. And for resources and support system, sometimes this lack of resources or support system cannot allow tight glycemic control. Higher hemoglobin A1C is associated with increased microvascular complication, and this was shown in UKPGS, and there was increasing macrovascular risk with increasing hemoglobin A1C. Again, in UKPGS, fatal and non-fatal myocardial infarction was increased with increasing hemoglobin A1C. And this is new, the effect of glycemic control on cardiovascular disease, and there was improvement of glycemic control and reduction of major cardiovascular events in 18 cardiovascular outcome trial. This is an updated meta-regression. So MACEs, for every 1% reduction in hemoglobin A1C, there was 26% reduction in MACEs. And let me explain that these 18 trials, or 18 meta-analysis, was done on DPP-4 inhibitors, SGLT2 inhibitors, and GLP-1 receptor agonists. And the DPP-4 inhibitors are in the blue color. We have 4 trials using DPP-4 inhibitors. And for non-fatal stroke, for every 1% reduction in hemoglobin A1C, there was 41% reduction in non-fatal stroke. So glycemic control still matters, and achieving hemoglobin A1C target less than 7% was shown to reduce microvascular complication in type 1 and type 2 patients when instituted early in the course of disease. And this is again the holistic person-centered approach to type 2 diabetes and the goals of care. And we discussed this previously. And to decrease hemoglobin A1C, usually there is increased risk of hypoglycemia and weight gain. When you try to be more tight, you're going to have hypoglycemia and increased weight gain. And in this trial, using sitagliptin or glimepiride in those inadequately controlled patients on metformin, 2 arms, sitagliptin 100 versus glimepiride from 1 milligram to 6 milligram, and let's discuss the results after 30 weeks. Sitagliptin was non-inferior to glimepiride in hemoglobin A1C reduction, but there was less hypoglycemia in the group receiving sitagliptin versus glimepiride, and also there was mild loss of weight of 800 grams versus increase in weight 1.2 kilograms in those receiving sitagliptin versus glimepiride. What to be considered when choosing DPP-4 inhibitor like sitagliptin? The dose is 100 milligram once daily for all patients except moderate to severe renal impairment. Dose adjustment is done 50 milligram once daily in moderate renal insufficiency with creatinine clearance more than 30 to 45, and 25 milligram once daily in severe renal insufficiency less than 30, and for end-stage renal disease requiring hemodialysis or peritoneal dialysis. And for patients in sitagliptin non-exposed group, they have similar rates of, so this is a proof of safety, cardiac disorders including MACEs, bone fractures, no any safety alarm, infections, angioedema, or angioedema-related events or malignancy, and less risk of hypoglycemia. And it's most widely prescribed DPP-4 inhibitor with indications across broad range of type 2 diabetic patients as an initial monotherapy and initial combination therapy for with metformin or with glitazones, add on to another medication, add on to metformin, SGLT2 inhibitor, sulfonylurea, glitazones, or insulin, and add on therapy to 2 agents, combination with sulfonylurea metformin or metformin SGLT2 inhibitors, or glitazones with metformin, or insulin with metformin. So it can be used as a combination in many combinations for except for sure the GLP-1 receptor agonists. Use in special population, it can be used safely in mild and moderate hepatic impairment, mild and moderate renal impairment, severe renal impairment with dose reduction, end-stage renal disease, hemodialysis with dose reduction, and in elderly patient more than 65 years. And let me remind you that the Canadian diabetes guidelines choose DPP-4 inhibitors as the most safe medication for older population. Thank you very much.